Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Welcome to the Teledyne Pulse. Today we have with us some guests from Columbus Community Hospital. We're excited to hear their perspective on telemedicine. Shane, you want to introduce our guests?
Well, absolutely, Andy. We're just honored to have a couple of esteemed guests on our podcast today, coming to us from Columbus Community Hospital in Columbus, Nebraska. The folks I know well over the years, and excited to introduce them to you, and excited to have them on our podcast today with Mike Hansen and Dr. Mark Howerter. So I thought maybe before we get going, Mike and Dr. Howerter, perhaps you could give an introduction of yourself and a little bit about yourself, and we'll get things going.
All right, I'll go ahead and get started, Shane. Mike Hansen, I'm President and CEO of Columbus Community Hospital. I've been in healthcare for about 42 years. I've worked in Louisiana, Texas, California, Iowa, and Nebraska. I became a CEO in 2005 and came to Columbus Community Hospital in 2009. So I've been here. It will be 15 years in November. And so it's just been an honor and a pleasure to be here in Columbus, and I've enjoyed every single minute of it.
Yeah, and Mark Howerter, I'm a ED physician. Been practicing emergency medicine for 35 years. First 5 years were in Indiana. Moved to Nebraska in 1994, so I guess that's 30 years ago. It just seems like that was just, a couple, 3 years ago. Time accumulates, doesn't it? I've been here in Columbus for 20. I've been the ED medical director for 20. I spent the first 10 years in Nebraska and Lincoln working in all three hospitals. And within the last year, our hospital decided, I think correctly so, that we needed a chief medical officer, and I was asked and humbled to be asked to be the first chief medical officer of the hospital, and have been growing into that position over the last year.
Well, that's excellent, and it's really, honestly, a couple of icons in healthcare in Columbus. So we're honored to have both of you here. And Dr. Howerter, I can remember taking your patients when I was still working 911 in Lincoln back in the day. So we go way back.
We were both a few days younger then.
Yeah, a lot of days younger. But it's great to have both of you. And again, the stuff that you have accomplished in Columbus and where the emergency department's come in 20 years, and Mike, where the hospital's come in 15 years, as you're the CEO there, have really got some amazing things accomplished. And I think before we hear a little bit more overview of Columbus Community Hospital and the great things that you've accomplished here over the last few years, thought tip the hat on why we're here today is really to discuss not only Columbus Community Hospital, but where the relationship came about in terms of your virtual care journey and the programs that have made an impact on Columbus Community Hospital from a virtual care strategy, including things like pulmonary critical care, inpatient nephrology and dialysis management, mental health triage, emergency mental health triage, and infectious disease stewardship programs, among others. But those will be a handful of topics we'll touch on and get to learn more about your journey as it relates to those virtual care strategies. But before we do that, there's so many amazing things going on in Columbus. I thought perhaps the two of you could share a few of your insights on what some of the exciting things that Columbus is doing.
Yeah, as you said, Shane, really this has been going on for the last 15 years. The board back in 2009 really had a great vision of transforming what was a small community hospital back then into a large regional referral type center. So that's been the focus of the last 15 years, and we have filled in pretty much all of the gaps that were there back then in terms of programs and services and facilities. And so there's been many, many projects along the way. Some of the bigger ones, we had an OR expansion back during pre-COVID and during COVID, actually. And then probably the largest project that we just completed in January of this year is our field house project. And that stems back to 2012 when we really had a wellness initiative. Uh, we do a community health needs assessment every 3 years, and back in 2012, it identified a lot of acute and chronic illnesses in our community. We had a obesity rate of about 33% back then. And so as a board, we sat down and said, what can we do in terms of brick and mortar to really impact the overall wellness of our community? And that resulted in the wellness center that we built in 2015. And then, of course, in 19, when we got approval to build the field house, that was really the second phase of our wellness initiative. And so we've built something that really enhances what we have at the wellness center, but also really expands all the activities and things that you can do to be active in your community. It also really addresses the mental well-being as well, because we know when people are working out and physically active, it impacts their mental well-being too. So we've had a lot of projects along the way. We're really proud of all those projects. But what was really amazing is in 2012, we paid off all our long-term debt, and all those projects have been paid for with cash from operations from the hospital and help from our foundation. So we're really have accomplished the vision that board had back in 2009. And we've gone well beyond that and continue to do that with our new project that we're looking at, which is a cancer center that will bring medical oncology, radiation oncology, and our infusion services all together in a cancer center concept.
Yeah, absolutely. The programs and the building blocks have kind of come together over that 15-year period, and certainly from the clinical perspective, the hospice program certainly is one of the cornerstone pieces in that. But kind of, Mike, to your point, in the board's vision of trying to sort of create, sort of get out of the Band-Aid station, if you will, as was deemed by some folks in the community years ago, to more of a referral type center. And what are the pieces and programmatic needs that you need to have in place to fulfill that need? And to your point, gosh, 60 active medical staff, 180 physicians recruited during that time is beyond impressive. And shout out to Amy Blaser and her recruiting strategy for sure. But beyond that is, how do you go about augmenting that service? And certainly the hospice program has been a significant addition there, as we do a lot of those programs in all different states. But beyond that is, how do you augment that to ensure that you can be that referral center? Sometimes that sort of lends itself to virtual strategies to help support that process. Case in point, one of the things that was identified as a need was patients needing dialysis care in the hospital had to be transferred because we couldn't offer it. So maybe if the two of you wouldn't mind going down a little bit of the road on how you decided virtual care strategies could play a role in helping you build to that more regional referral center, as opposed to maybe not being able to provide that care.
Yeah, and everything Mike said is absolutely correct, and kind of impressive what's happened just in the last 15 years. And 20 years ago when I got here, it was a community-based hospital that really had kind of limited capabilities, and definitely in the last 15 years that's expanded greatly. We opened a cardiology cath lab, a cardiac cath lab, within the last 3 years. And prior to that, everybody that had a cardiac emergency had to leave town. We've had kind of gone from a one-person ENT clinic to a robust three-person ENT group, and so we have ENT coverage 24/7, 365. We've really increased psychiatry. Psychiatry used to be a complete afterthought in Columbus. We have a very robust inpatient senior behavioral health, and then an extremely robust outpatient psychiatry clinic that covers everything from child to geriatric patients, and with a huge need in our community. And as Mike mentioned, the cancer center is on the horizon, which is also, I think, a huge need in our community. So I really think that, as Mike said, the board's vision in 2009 to address the needs of the community have been largely addressed, and we're kind of just down to fine tuning things at this point, because a lot of the big projects that really needed to happen have happened in kind of an impressive fashion over that time.
Yeah, and in terms of providers, during that time, we've recruited about 180 physicians into our community. So we have about 60 active medical staff now that are here 24/7. And then we have 100 or more visiting physicians that come in from Omaha, Lincoln, and other places. So the quality of our medical staff is just phenomenal for the size community and size hospital that we have.
Yeah, that's really true. When I got here, the ED group was contracted out, and we've had our own ED group for the last 20 years, and it's been a very stable group. But I think that one of the bigger additions was converting to a hospitalist-based model, and I know Shane, you were involved with that when you were here at the inception of that, and Mike was instrumental in making sure that happened. But we have, I would say, one of the best hospitalist groups for a hospital our size in the state. We're really blessed to have a really strong group.
Yeah, Shane actually put together the pro forma for that, and that was a big paradigm shift for our physicians, and obviously it has worked out extremely well over time, and given our local physicians a better quality of life. And we are just really pleased to have the adult hospitalists, but in the last few years we also added pediatric hospitalists. So we've got a full hospitalist team that really takes the pressure off our local family practice docs and gives them a little bit better quality of life.
Yeah, and to Mike's point, especially that last point, I think is really important to get these services into our community. It's almost impossible to recruit a physician to be in solo practice and be on call, 365 days out of the year. Most everybody correctly wants to be in a group where they can share that burden. Or sometimes we don't need a full-time person. What we need is a one-third time person or a half-time person. And so you can't really recruit to that. And so the really the only alternative, the best alternative, I think, is to go with a telemedicine model where a specialist can share his talents throughout several communities, and then we can use them or need as much as we need. And obviously, if we ever got to a point where the demand became so much that we could recruit into a full-time model, then we probably would. But a lot of these areas like infectious disease, pulmonary medicine, psych triage, those are just things that we really need to augment what we're doing. But we really couldn't recruit to that in a full-time basis, at least where we are right now.
Yeah, I can't agree more. The programs have really been beneficial for a lot of different rural communities on all those points that both of you have made. And I can think back too in the emergency department without the emergency mental health triage, for example, where patients were discharged or sent to a prospective mental health facility to then be reevaluated in the ER and discharged from the ER. Maybe you could speak a little bit to do you recall any dissatisfaction phone calls?
Yeah, that was a huge dissatisfier. But dissatisfier for the patient, dissatisfier for the provider. It was, the correctly any inpatient unit wants to be able to triage patients to decide, are they appropriate for our unit? Do they fit in our milieu? Do they meet criteria? And it's really the sort of thing that they need to interview the patient. And so, the standard was that we would say, gee, we think you might meet criteria, but we don't know. We would call the unit and they'd say correctly, well, we need to interview that patient. So we would pack them in a car and send them, 90 miles away. And there was maybe a 50-50 chance they'd actually be admitted to the hospital, or they might be turned away and come back to the community. And of course, they've now, in their minds, wasted about 3 hours of time. And the person directly responsible for wasting that time was me or one of my colleagues in the emergency department. So you're right, that was not a big satisfier. So we leapt at the chance to be able to do those virtually, where they get the mental health triage right in our department. And not only do we get an answer in terms of do they meet criteria for admission, But if they don't meet criteria for admission, then they start working on outpatient plans to help this patient because they clearly have a need. Maybe they don't need inpatient, but they clearly have a need. And so they can help us fill the gaps in terms of what do we do for outpatient management. So that's been not only a huge satisfier, but just an improvement in patient care.
For sure. It's a very popular program, and I know that many of the hospitals have found great value in that program. And certainly one of the things we definitely learned as part of that program was patients that were, whether they were sent with private vehicle or by a squad to a mental health hospital, the bottom line is the disposition would just change over the course of 30 minutes or an hour and a half, or 2 hours. The interview that would happen in real time in Columbus was different than it was going to happen in Lincoln an hour and a half, 2 hours later. Stuff changes, their outlook changes, and so yeah, it's been such a need, and so that was a great call for Columbus to sniff that out and address that the way that you have. So that's been a great success. How about maybe you could talk a little bit about the impact as a whole related to various departments or medical staff. Do you find that the medical staff or your hospitalist team, for example, feels like they have more confidence in their practice capabilities with the augmentation of these types of services? What are your thoughts there?
Yeah, it's a good question, and obviously, we were able to recruit a lot of providers because we have such a good physician recruitment team. But as you know, trying to recruit to a small rural town is very, very difficult. And so, although we've really become that regional provider, and we are pretty much a full service general acute hospital, there's still going to be gaps, especially when you look at specialty areas. And so that's where you have to bring in either locums or telemedicine into the picture. And so in the beginning, I think, Dr. Howerter, we only had teletrauma and worked with Nebraska Medicine on that. But a great need was really defined when the pandemic hit and having pulmonology critical care. And that's where that came into play and was extremely helpful during the pandemic. And then mental health, as Dr. Howerter mentioned, was a black hole in 2009. And we really started out as a board thinking about, okay, how can we address behavioral health as it's probably one of the biggest concerns in terms of our community needs. And it really started out with telemedicine and telehealth through our ED for the psychiatric care. And then as you said, Shane, with nephrology, we had a lot of patients going out of town. They were here in the hospital for different reasons, but they also needed dialysis, and so we had to figure out a way with a small number of those types of patients to provide nephrology care, and that's where telenephrology came into play. And then infectious disease is such a specialized area. We really can't afford a full-time ID physician here in our community. And so, again, telemedicine is a great option to bring those services into our community.
Yeah, no question about it. Dr. Copples, who's our lead hospitalist, and I were having this conversation earlier this week. As Mike pointed out, it really took off and became highly necessary during the pandemic, especially with all the respiratory disease that was associated with the pandemic and the people with severe respiratory issues. And that coupled with the fact that the tertiary hospitals in the area were at capacity and our ability to transfer was really very limited to almost non-existent. So we really needed that support. But what's grown out of that is one, the capacity of our tertiary hospitals has not really improved post-pandemic, not like we thought it might. Some of that has to do with personnel shortages, especially nursing shortages. Some of that has to do with the fact that there's just more, I think the post-pandemic medical needs grew because a lot of people neglected their health, and so we're seeing a lot of things that grew out of that neglect. And so our ability to get people to tertiary hospitals has really diminished. Um, but getting used to doing more critical patients in our hospital with the augmentation of, say, pulmonary critical care is something our nursing staff and hospitalists have gotten used to. And it isn't just the hospitalists being used to it. I mean, the hospitalists, I think, felt like that was great support for them, but we also needed to get our nursing staff accustomed to taking care of these sicker patients. And I think the nursing staff has greater confidence in doing that too, because they have the access of critical care doctors also involved with the care. So I think it really helps on both fronts. But we're using those resources at least two or if not three times a week on two or three different patients per week for not only respiratory critical care, but even other types of critical care like septic shock, people that are requiring vasopressors, other issues that are just not as common in our hospital, but with the use of pulmonary critical care in particular, it's just made it more comfortable for the docs. I think they feel like they've got more support, and I think our nursing staff feels like they have more support, and so it's been a huge benefit for them.
Yeah, I appreciate all that. I can recall a conversation with a patient that had received the inpatient dialysis program who had previously been transferred several times over the course of obviously those CKD patients tend to visit hospitals occasionally, and they had been transferred prior to that, and were shocked that they were able to stay at home, and we're so thankful that you all have that service in place. So that's been phenomenal service. And certainly, one quick question related to the obviously from the nursing side of the equation, and you bring up a great point in terms of the theory to all of a sudden keep sicker patients is great, and you have the augmentation of critical care, and you have the hospital support. The nurses that haven't taken care of those patients before may be a little anxious about something like that. Can you kind of describe what you're hearing from the or from the nursing side of the equation, and maybe some of the steps that were taken to overcome that barrier?
Well, number one, we have a great nursing director now who's really involved with nursing apprenticeship and nursing education, and so that is a critical component to getting nurses adjusted to taking care of sicker patients. But the other part of that is just exposure. The more often they see these patients, the more comfortable they get. So you just can't replace experience. And honestly, like I said, having 3 or 4 consults a week get our nurses, especially in the ICU, in a position of seeing those patients on a fairly routine basis now. And so that the education component in our hospital is very, very strong. Nursing leadership is very strong, but they're also getting the repetitive exposures. So the comfort levels just continue to increase.
Yeah, that's great. And how about Dr. Howerter, from your perspective from an ER physician, and knowing that you have these services in your back pocket, so to speak, that can help augment the hospitalist team. If you think about your journey in 20 years there, where you started with no hospitalist team and having to track down the various primary care physicians, to having the hospitalist team in place, to then knowing that you have, gosh, the hospitalists, we don't have pulmonary, we don't have nephrology, we don't have ID. What type of an impact does that make on an emergency department provider to have those resources now available as part of the continuum of cares?
Oh, I could go in a ton of different directions with that. When I got here, I felt like we led the league in filling out the transfer forms. We filled out a lot of transfer forms, and the road between Lincoln and Columbus and Omaha and Columbus got worn pretty thin with all the ambulance runs that we did. Not that we still don't do ambulance runs, but we had a very itchy trigger finger back then. We just sent a lot of patients out, and that kind of became the culture simply because the capabilities in those hospitals far exceeded what we could do. Now that gap is narrowing, we don't have to transfer as many patients, so it's an easier life for us. Whenever you're transferring a patient, the first thing we have to do in the ED is make sure they're stable enough to be transferred, because they're going to be experiencing paramedic time. Not that paramedics aren't good, but the idea is to get them from doctor to doctor, correct? And so we have that hour and a half paramedic time. We have to make sure they're stable enough to make the trip. So that increased the ante on us quite a bit. Um, so that's a huge shift. But I think also the it, 20 years ago, the ability to get patients to hospitals outside of Columbus was a lot easier. Everybody had capacity, and it really wasn't much of a trick. These days, if I call a tertiary hospital, the most likely thing I'm going to hear is, "We are at capacity, and you're on a waiting list." So it behooves us to take care of those patients. So I don't like those patients having to stay in my emergency department for 2 or 3 days, knowing they're not getting the care they need. The fact that we can take care of sicker patients here is just a better scenario. And I'll tell you, there's not an ER doctor in the world that doesn't love having a hospitalist group. That's it. They're given the choice between a hospitalist group and not a hospitalist group, and it's simply just availability. They don't have other demands. They're not trying to manage an office and work around lunch hours and that sort of thing to help you with patients. And I always felt like when I was calling a family doctor, that it was probably an imposition on them, and I'm pretty sure it was, because they were really tasked with a lot of things, and then we just added to their burden. Whereas the hospitalists, this is what they do. And so it feels like I'm not overburdening someone when I call them, and I'm sure I was overburdening our family doctors, because that's not an easy life, taking care of a full stable of patients in your office, and then maybe having to break free and go see somebody in the emergency room or in the hospital, and getting calls from the nurses constantly. Yet you're still trying to manage a full office. That's almost an unmanageable situation.
And I would add, from the patient perspective, healthcare is local. Patients want to stay local if we're competent and capable of providing that care here locally. It's a real burden on families to have to go to Omaha or Lincoln, and it adds a lot more expense as well. So if we can augment things through telemedicine, telehealth, it just allows patients to stay here locally, which is what they really want to do.
Yeah, I can't agree more, we've definitely heard the emergency department physicians and the high level of satisfaction with both hospitalist programs and the augmentation of those hospitalist programs. Mike, how about in the community? What do you hear from patients and primary care physicians in the community, and in terms of physician retention, physician recruitment strategies, and the ability to articulate, yes, we have pulmonary critical care available, we have nephrology, we have ID, we have all these programs along with our hospital program. What kind of an impact do you see on that front?
Yeah, so obviously I've seen a lot of change over the last 15 years with community perception about our hospital by adding the providers that we've added. And when you add a great provider into our community, they just help attract other great providers. So we've kind of snowballed in that respect in terms of bringing some really high quality physicians into our community. And then again, all the programs and services and all the facilities that we've built, we've got a great hospital here, but until people actually experience it and come in and see the culture that we have here and the facilities that we have here that are state of the art, some of the people still have that same old perception that, care is better in Omaha and Lincoln. But the fact is, what I've seen over the last 15 years is not only have we created a great regional hospital and we get people from all around our region, but we're also seeing people coming from Omaha and Lincoln to Columbus to get care with some of our surgeons and other providers. So we're starting to see that in-migration as well. And then, I talk to patients that have come from the bigger hospitals in Omaha and Lincoln, and they talk about, the quality of care that they get here, but I think even more so the culture that our staff has here, and the nursing staff especially. It's just a much different experience that they have here versus Omaha or Lincoln. So I think people really, that perception has really changed over time, and I think people are proud of the hospital that we have in this size of a town. And some of the things that we've done, like the field house, for example, in terms of impacting wellness, is far beyond what you'll see in other small towns and like-sized hospitals.
Yeah, I agree that the campus is sprawling and it's significant, and it's a significant piece of the community as a whole. And kudos to all the amazing things that you've been able to accomplish in the last 15 and Dr. Howard in 20 years there. It's been an impressive run for sure. Um, I guess two last things then, Mike. I don't know, did you happen to grab any metrics or any data points at all?
Well, as far as financially, the hospital has grown tremendously. We've more than tripled in size. It was a $40 million operation when I got here in 2009. Today, we surpassed the 300 million gross revenue mark and about 150 million net revenue. So it's grown financially, and as I said earlier, we have no long-term debt. More than 50% of hospitals across the country are in negative margins right now. It's a tough time with, the pandemic and the economy. We just finished our year with a positive margin again. So we're in great financial shape, probably in the top 5% of 5,000 hospitals across the country. As far as numbers, our numbers continue to increase both on the inpatient side and the outpatient side. Obviously, telemedicine, telehealth has enabled us to keep a lot more patients here than we had in the past. So I think that's been a plus. And then, as I said, from a patient perspective, if they can get care here at home, that's what they prefer, and I think that's really impacted things as well. But our ED volumes, for example, have continued to go up year after year. I think we're close to 13,000 visits a year now. Our inpatient numbers continue to go up. Our outpatient numbers, it's just unbelievable how many outpatient visits we have, and it just keeps going up and up every year. So we're continuing to grow, and I don't know when that will plateau, but it hasn't for 15 years, and we just continue to see more. We do a lot of outreach to critical access hospitals around us. There's probably a half dozen or more critical access hospitals, so we provide outreach with ortho and ENT and other services as well, and we'll continue to do that. So we have a great relationship with those hospitals as well. And again, we believe the same thing. Healthcare is local. If they can provide care and be competent in a town of 1,200, we want to enable them to be able to do that. So we try to help make that happen.
Yeah, that's spectacular, and certainly not all hospitals have that same position to try and help, enabling the local entities to help them take care of patients locally. That's an impressive piece that is definitely viewed upon very positively, particularly in the rural market. Related to the emergency department volumes increasing, one of the, it's an interesting perspective on there where the volumes have increased in the emergency department. We've had a similar scenario in a hospital system we work with in Missouri, where their ED volumes actually increased by 34% after a 4-year period, and it increased every year. And basically, what we found out as part of that analysis was that the community was essentially bypassing the hospital, going to the tertiary centers without going to the local emergency department because they were, quote, going to be transferred anyway. And so why would I go to the hospital if they're just going to load me in a bus and send me down the road? And I've been in those buses for years, way back when. It's not the ideal ride. So it's likely, somewhat of a hypothesis at this point, but some of the emergency department volumes I would predict would be related to an increase in confidence in the community and surrounding communities in coming to your emergency department, knowing that, gosh, I'm going to be able to stay at home or at least closer to home than I would be going to Lincoln or Omaha.
Yeah, I am certain. I am certain of that. 20 years ago, we were seeing just a little bit north of 6,000 patients a year. In this last fiscal year, I think it was 13,400, and the community has not doubled in size, but our volumes have. So I think there's a huge component of that, and it's, I think, the thing that's really key in Columbus is we've had physician growth, but we've also had physician stability. It's really remarkable physician stability. We of course have retirements, and there's always a small underlying level of movement and transition in physicians, but we haven't had wholesale transitions like some communities can experience, and that helps a lot. And as Mike said, good attracts good, and we have good physicians in our community, which makes it easier to attract other good physicians. But coming to a community of 25,000 people is an intentional move, and so our market of physicians that we can recruit is a little more limited than if you were, say, in Omaha or Lincoln. But even given that, we've been able to recruit excellent physicians, and that has just given, I think, our community a lot of confidence in our hospital.
The other piece on your comments related to the community needs assessment related to the obesity and the relationship between the Y and the field house, maybe you could touch on that.
Yeah, so when we looked at that community health needs assessment back in 2012, we approached the YMCA board because the YMCA, which had been in town for over 100 years, the facility they were in was virtually crumbling down around them. They had decommissioned their pool about 3 years earlier, and really they had no money to do anything. So we approached their board and said, we're going to build a wellness center. It's going to be about 86,000 square feet. And on one side, we're going to provide medical wellness, which is all our outpatient rehab services, OT, PT, speech, pediatric rehab, and so on. And on the other side, we want you to provide general wellness, your Y activities. And what we did was we structured a 10-year lease, which started out below fair market value and ratcheted up to fair market value over 10 years. So we're almost to the 10th year of that now. And so that helped them get back on their feet, grow their membership, and things were going extremely well. Their membership grew by about 60%. Our volumes grew about 60% on the rehab side. And then, of course, COVID hit and things kind of flattened out for a while. But after COVID ended, we've gone beyond our numbers, and the Y has as well. And then, of course, we added the field house aspect to things. And so we did a pro forma, and we projected that in 3 years after opening the field house, their memberships would go to 4,000. Well, we were already at 4,000 after 2 months of opening the field house, and today we're over 4,500 memberships for the Y. And so it just continues to grow. It's a great asset for our community that will impact the wellness of people for generations to come. But more than that, it also really impacts economic development here in Columbus because it's bringing people from the region. And I was just talking with the governor the other day. He asked about, well, where are these people coming from? They're not only coming from our region, but they're also coming from Omaha and Lincoln to be members at our field house because it's such a phenomenal facility. And so, when those folks come in from the region, they come in from out of town, they're going to be utilizing hotels, they're going to be eating out, they're going to be getting gas, and they're really going to impact the overall economic development and financial position of Columbus.
Yeah, no, spectacular. And refresh my memory in terms of the size of the facility, how it compares to other similar sized facilities. I know it's pretty high in terms of where it sits across the country.
Yeah, and we did our due diligence prior to building it. We went to field houses and sports complexes all over the country. And so we took the best of everything. We learned what to do and what not to do. But it's probably the largest complex in the region in terms of towns our size. It's the wellness center, as I said, was 86,000 square feet. We added on to that, so that's probably more like 100,000 square feet. And then the field house itself is 260,000 square feet. So it's quite the complex, and it has everything you could dream of in it. We're getting people from all over the country and Omaha and Lincoln coming in to look at it because they're contemplating doing something in their communities as well and want to see what it's all about. But for a town this size, it is a state-of-the-art field house and wellness center that, and I think now with the Y side of it, they are the largest YMCA in the country.
Yeah, a lot of great things going on in terms of the wellness. And Dr. Howard, I don't recall seeing you there in your racquetball clothes recently, but
I probably need to. I'm just positioned here in the ED, just taking care of people that have their aches and strains after they're playing a good game of racquetball. So somebody got to pick up the pieces, right?
Well, and then Shane, you talk about, recruitment. It's a great asset to have when we're trying to recruit physicians and staff into our community. We have great schools, we have a great hospital, now we have a great wellness complex, we have a great child care facility. Those are all factors and things that really have an impact on our ability to recruit and retain high quality people.
Well, that's excellent. How about the future? What does the future look like? You've done all these great things over the last 20 years, Dr. Howard, or 15 years, Mike. Well, what's the next 5 years look like? What does the future look like in terms of Columbus Community Hospital and additional virtual strategies, or what do you think in the future does look like for you?
Yeah, so the two things that I really focus on are financial sustainability, number one, and then number two, workforce. Obviously, there was a nursing shortage prior to the pandemic, as Dr. Howerter mentioned, and then also it's just been exacerbated by the economy and things like that. Travelers, went and left and traveled. But so what we've done is we've realized that we have to kind of build our own. And so we start in the schools. We have a pathways program in all of our high schools that teaches people about healthcare, occupations, and what you can do in terms of healthcare, not just the doctors or nurses, but all the different classifications that we have here. And then the apprenticeship program is in its third year, and so we're starting to see the fruit of that program. And that's where we have people that are working, that we help pay for their school, and we're starting to fill in the gaps there. We're working very closely with all the nursing colleges. We helped CCC build a nursing building. And then we're also providing some instructors now. Some of our MSN trained nurses are instructing at the colleges, both at CCC and UNMC. And we're actually getting some reimbursement through NHA for doing that. So that enables them to really increase the class size. And for the first time in a long time, CCC is full. And because nursing instructors were also hard to recruit and a big problem for the colleges. So we've helped fix all those things, and so we've kind of built our own pipeline, and so we're starting to see that really make an impact on our ability to get nurses. But also looking into the future, having served on the AHA Regional Policy Board, virtual nursing is also something that people are starting to look at to fill those gaps. So I'll be excited to kind of see how that develops. And I've had the opportunity to go to some of the bigger institutions to see it in action. But virtual nursing may be something in the future that we'll have to look at as well as it gets tougher and tougher to recruit nurses to fill our needs. So and then, of course, we mentioned the Cancer Center. I think that will really be fabulous to have all those things in one place. It's going to be just west of our emergency department, so it'll have close access to the ED and radiology and pharmacy and all that. So I think that will probably be one of the largest projects that we'll do for the next 5 years or so. Beyond that, there wasn't really much left on that initial vision, maybe a hospice house at some point. But then we're also going to have to look at some of the other social determinants of health. Housing is a big issue, so we'll have to look at housing and see if there's anything we could do to partner with folks there. And then food security and other things like that. We'll just look at all the different social determinants of health and see how we can partner with other entities in our community to address some of those issues too.
Yeah, and then I think looking at how healthcare has evolved over the last 20, 30 years. I mean, I'm amazed at what we do as an outpatient now that was exclusively inpatient when I first started in medicine. And just been this continuous shift from inpatient types of models to more outpatient types of models. And I think that one of the things that we're probably going to see is more and more in-home types of services being needed. And I think what Mike mentioned about the virtual nursing probably is going to play a big role in that as well. The payment models and criteria that get used have really kind of forced the hands of medicine to really kind of shift more from an inpatient model to an outpatient model. And I think we're probably going to see that continued growth. I mean, I kind of feel like hospitals at some point are going to be intensive care units, and the less acute things are probably going to be maybe started in the hospital and then shifted to outpatient more and more quickly as we go. So that's going to require bandwidth to do that, and probably some type of virtual nursing will be absolutely essential for that. The other thing that I have noticed over time is that I think when I got out of medical school, the majority of physicians were entrepreneurs and kind of interested in private practice and kind of running their own show. And what we've seen over time, and a lot of this is dictated by economics, but more of an employment model is really kind of the goal of most physicians coming out of practice. There's a lot of moving parts to practice right now. There's a lot of the most heavily regulated industry there is, and to understand all of that and try to be an entrepreneur and run your own practice is almost too much to do. So we're seeing that more and more physicians are really wanting to be part of a hospital system and even employed by a hospital, so that they don't have all of those headaches because the hospitals really have built-in systems to deal with all those regulations and issues. But along with that, I think most physicians are also cognizant that there's a lifestyle demand that they would like, and so to some extent that requires that we have enough infrastructure to make sure that you're not on call 24/7, 365. So we do have to create models to help. And this is a recruitment tool. And a recruitment reality really is that we have to create lifestyles for physicians that are doable, and we're more cognizant of that now than think we were 20 years ago. So those are some things that I see from just kind of the vision of where medicine is going, and I don't think that's going to lessen at all. I think that's we're going to have to continue to be really aware of how physicians want to practice, and really the idea is to put physicians in a good position so they give the best care. So we don't, an unhappy physician isn't going to give the best care. So it's not something we can just ignore.
And I would add to that, with the baby boomers retiring and we are getting a lot of younger physicians, I felt it was really important to have a physician mentoring program. So Dr. Howerter has developed that program and will be implementing it here shortly.
Uh, in terms of the virtual nursing component, that's one of our newest services, and I can't agree more that virtual nursing is definitely a major factor moving forward. And it depends on the area and the location, but certainly one of the things we've seen in the market is the nursing experience and knowledge base is challenging, particularly at night, but in some cases even during the day, where it kind of gets back, Dr. Howard, to that pulmonary critical care discussion, how the nurses were a little uncomfortable with some of those patients until they evolved and they get that real time experience. And so the ability to augment those types of situations and scenarios where a nurse hasn't been around that type of scenario before, but to rely on an expert nurse that can help them through that and ask questions and present different ideas to them and sort of hold their hand in a real time mentoring type of strategy will play a big role, along with patient sitting. So both of those are definite factors moving forward, and I can't agree more. They're going to play a role not only in the acute care space, but in the outpatient space, and in some cases, hospital at home. Well, hey, I think it's been a great conversation, and I think it's been great to learn more about Columbus Community Hospital, where you guys have grown to here in the last 20 years and 15 years, and where your plans are moving forward. And it's great to be able to share all the amazing things that you've accomplished, which is a lot. It's just an amazing story. So congratulations on all the hard work over the last 15 and 20 years, and I expect nothing but more great things to come. from Columbus Community Hospital. So I really appreciate you taking the time.
Thank you, Shane.
Thank you.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@teledigmhealth.com. For more information or general inquiries, please visit teledynehealth.com.